Dr. Das, you have to unmute. Yes.
Good morning.
Yeah, good morning. So we'll start. Today we have a operative scenario discussion. The operative scenario discussed will be a lap cholecystectomy, and you'll find the operation is almost same except the excess. And we will also discuss part of the open cholecystectomy. Dr. Onkar Nath is a third-year junior resident at MR Bangur Hospital. Will present the scenario, and Dr. Das will take us through the scenario. Dr. Gautam Das is professor of surgery at IPGM SKM Hospital. Dr. Das, we are discussing the cholecystectomy. You will start like an exam scenario. Onkar.
Good morning, sir.
Dr. Das, we can start. You can just asking him with
Yes, you can start.
yeah.
Hello.
Yes, Dr. Das, a little louder.
Can you hear me?
Yes, yes, we can hear you. Please
Okay.
start. Dr. Onkar is present. Will be presenting.
Volume টা কম পাচ্ছি।
ভলিউমটা একটু বাড়াতে হবে। একটা মাইক্রোফোনের সিগন্যাল আছে। But you are audible. We can start.
Yes, you can start.
Yeah. Am I audible to you, Dr. Das?
Yes, yes.
Okay,
Volume is
so
slightly
we can
low.
start in the proceeding that Onkar, you have got a card of lap cholecystectomy. So the first question will obviously be, what are the indications of laparoscopic cholecystectomy? Tell us the indication of laparoscopic cholecystectomy.
Sir, chronic cholecystitis, acute cholecystitis, porcelain gallbladder, acalculous cholecystitis, cholesterosis of the gallbladder.
You are doing gallbladder
Gallbladder.
surgery every day, so you should not be
Gall-
missing the common indications.
Gallbladder polyp,
You just cannot say gallbladder polyp. You have to specify some points. All gallbladder polyp does not require.
more than 1 centimeter.
Yes,
Gallbladder polyp more than 1 centimeter.
or symptomatic gallbladder polyp. Then
Porcelain gallbladder,
you have said already. Next,
traumatic rupture of the gallbladder,
don't go to rarer things before you finish up the usual list. There are other gallbladder conditions where you need to do cholecystectomy, like mucocele gallbladder.
mucocele gallbladder, empyema gallbladder.
Yes. What is a incidental cholecystectomy? Incidental cholecystectomy. Do you need to remove the gallbladder in course of other operations?
Yes,
Like
like sir, in case of cholecystectomy after ERCP stenting.
Oh, that is a primary gallbladder pathology. That you are doing procedure for gallbladder pathology. I am asking, you are removing the gallbladder, while the gallbladder is not at fault. There are some surgery where you remove the gallbladder as part of the other procedure, like we just discussed.
Whipple's procedure.
Yes, in Whipple procedure, you remove the gallbladder. Second is, we discussed last day, colorectal cyst. In colorectal cyst, gallbladder is not the primary pathology, but you remove the gallbladder. Okay, you said acute cholecystitis. What are the situations in acute cholecystitis, and how do you decide to proceed with cholecystitis in acute cholecystitis?
If patient
In
comes
some-
within 2 hours,
Some situation, if you the problem is in liver, you do some liver resection, then you also have to remove
Yeah.
gallbladder.
Yes, you are doing right hepatectomy. You have to remove the gallbladder. Okay.
so if patient comes within 72 hours,
There is no such guideline now. This is all as per Tokyo guidelines. In Tokyo guideline, the acute cholecystitis has been graded, and the whole management depends on the grades of cholecystitis. Okay. So if it is grade 1, the prime indication is immediate cholecystectomy. Okay, resuscitate cholecystectomy. And grade 2, grade 3 are situations where the surgery is more difficult. But if you have an experienced center, surgeon is experienced, after resuscitation, you can proceed. But grade 4 is a situation where the patient has got as an organ dysfunction. In that case, you should optimize the patient. Some patient might require a percutaneous cholecystectomy, and then optimize the patient. Then all a blanket statement of
Yes.
all acute cholecystitis within 72 hours will go for cholecystectomy. It may not be the right step at the moment.
Yes.
Okay, Dr. Dash, please.
Yes, yes,
Indication
yes.
is discussed.
Yes.
You are audible. Yes.
Yes. Indication you have told, and just
Dr. Dash, you can summarize at the end. Let him proceed with the
Okay.
exam scenario. And
Okay.
after that, we have some time, then you can just share what should be the salient steps and how should they describe the ideal scenario.
yes, yes. Can you hear me?
Yes, yes, you're audible.
So you just mentioned the indications. Some indications are for gallbladder itself, and you have mentioned acute cholecystitis, and it should be symptomatic. What about asymptomatic gallstone?
asymptomatic gallstone.
Because you probably know that most of the gallstones are asymptomatic.
Yes.
So
Even-
if you got a stone in the ESC, the patient has no symptoms, what will you do?
If there is presence of comorbidity like diabetes, then we will go for cholecystectomy in case of asymptomatic gallstone also. If there is endemic zone, if there is high risk of gallbladder cancer in the zone, then we will go for cholecystectomy. If patient is single stone more than 2.5 centimeter, then we will go for cholecystectomy. If multiple stones, multiple asymptomatic gallstone, then we'll go for cholecystectomy.
Yes, also in very young patients also, because you know if long association with the gallstone may lead to malignancy. So if you discover in very young patient, then also you can proceed for cholecystectomy. Then
So the answer to this question will be routine cholecystectomy in silent gallstone is not advisable. Number one. Second is, as you said, patient with comorbidities, patient who are immunosuppressed, patient who are waiting for organ transplantation. Okay, in these situations, you should remove a septic focus. And apart from this, the people living in the endemic zone, patient who has got family history of malignancy, young patients, they are the patient where you should consider cholecystectomy.
Also, when you are going for a laparotomy for any other reason in upper abdomen, and then you can do cholecystectomy also.
And the recommendation from Tata Memorial Hospital is the northeastern India part of India is a high endemic zone for gallbladder cancer, and there is a clear indication for performing cholecystectomy in this patient population if they are otherwise fit for the surgery.
What form of cholecystectomy you want to?
Yes, sir.
What surgery you like to do in a patient with gallstone disease?
Sir, laparoscopic cholecystectomy.
Why?
Sir,
Why?
it has less post-operative time.
First, say it is now the gold standard operation for gallstone disease. It has been established. Lap cholecystectomy is the gold standard for gallstone disease. That's why you're doing. Why it become gold standard? Because of the factors you're now mentioning. So your point in favor is a gold standard surgery for gallstone disease. That's why I allowed for lap cholecystectomy. Now you say, what are the reason that it become the gold standard? Why?
Less post-operative pain, less hospital stay, cosmetically better.
Yeah. Early return to activities.
Early return to normal activity.
And demand by the patient. It has grown and become standard because the patients are opting for this form of surgery.
And also, it's very important, early return to work. That is very important.
Yeah.
Okay. Then describe the steps.
First, starting with the anesthesia, we'll go for general anesthesia with endotracheal intubation. And after antiseptic dressing and draping, patient should lie in the supine position, and 1 centimeter intraumbilical smiley incision should be made.
May I ask you one question? Maybe asked by patient party also. You have to face. The patient has come to you with gallstone. Problem is in the stone. But why you are removing gallbladder? Because suppose there is a stone in the kidney, you do not remove kidney. Why the operation is cholecystectomy? Patient party may ask you. Why is that?
How will you counsel? How will you counsel the patient relative that, or the patient himself, that the patient needs a cholecystectomy?
Because in the long term, it can lead to malignancy.
Where has said that? You are treating gallstone disease. What is the rationality for removing the gallbladder? In the kidney, you are not removing the kidney. Why in the gallbladder you need to remove the gallbladder? You don't have the answer. Try to understand. Why has the stone formed? Stone has formed because of number 1, lithogenic bile. Number 2 is a acidic infection and biliary stasis. And because of these 3 factors, the stone has started forming in the gallbladder itself. So in the gallbladder, there is a focus of infection. There might be a nidus around which the stone is formed. And if the patient has got repeated attacks of cholecystitis, gallbladder would have been fibrosed. The contractile function of gallbladder might have gone. So now then you have removed the stone and repaired the gallbladder wall. What is going to happen next? Next is the gallbladder may not be functioning, or the same lithogenic bile is there, same gallbladder is there. So patient may form recurrent stone. So that is the reason.
Yes, in one word, you can say that when the stone forms in the gallbladder is diseased.
Yes.
Somewhat.
Gallbladder is diseased. So you don't like to
gallbladder is not functioning properly. So there are several functions of gallbladder. It is not functioning properly. So you have
then I'll ask another question. And a lot of people have the idea that if you remove the gallbladder, he will lose the digestive function.
Yes.
How will you counsel the patient? How will you counsel the patient that his digestive function will not be altered with cholecystectomy? Now, these are more important. Counseling and other things are more important for
Yes.
operative decision. How will you counsel the patient? The removing gallbladder will not alter his digestive function.
Bile, sir, bile found by the liver.
Yes, very good. We start with that. The bile that is required for digestion is secreted in the liver. And what does the gallbladder does?
Storage and
concentration of the storage, concentration, and delivering the bile into the GIT after feeds. That is the function. So the bile secretion will continue even if you remove the gallbladder, number one. And this function of gallbladder of storage and concentrating will not be there. That's true. Then where is the bile will be stored? That is the point you should convince that next, when the gallbladder is diseased, the bile will be stored in the bile duct itself. You see, in the post-op period, there is some dilatation of the bile duct. So you have no worry that you will have failure of digestion because the bile is secreted in the liver. It will continue to secrete. Instead of gallbladder, the bile will be stored in the bile duct. And after feed, the relaxation of the sphincter, it will go. So you'll have no concern regarding failure of your digestive function. So that is how you should counsel the patient.
Yes. So gallbladder, you can dispose of gallbladder without hampering physiology too much, not like kidney. So these are the answer. Gallbladder is diseased, and you can dispose of gallbladder without hampering much physiology. So you can proceed for cholecystectomy. Then, yes, proceed for steps.
1 centimeter is smiley is inframumbilical incision is made, and after that various needle is inserted very smoothly so that the underlying viscera is not injured, and after the insertion of various needle into the peritoneum, we will check whether it has been inserted in the peritoneum or not.
Can you feel how the varus needle, whether varus needle enters in the peritoneum? Any feeling? How you hold the varus needle?
Yes, sir.
Show the grip. Finger
the grip. So the grip. No.
Not like this.
Not that.
It's like a dart. It's like a dart. You are holding a dart. You have two fingers here, and then the guard, ring finger will act as a guard.
Yes.
So the veneer has to be folded like a dart.
Like this. And if you are experienced enough, you can feel that it has entered the peritoneum. What is that?
What will happen once you puncture the abdominal wall layers?
There is loss of resistance.
Yes, don't push further. Once you have loss of resistance, and you can appreciate the click.
Yes.
You can appreciate the click in the needle where the stellate is pushed outward. Once you are in the peritoneal cavity, this stellate will go in and there will be clicking sound.
After that, we will test whether varus needle is inserted correctly in the peritoneum.
Yes.
We will go for drop test.
Drop is afterwards. First is you aspirate. Once you are starting into this, first you aspirate. If you aspirate gut contain, you aspirate urine, you are in the wrong place. Ideally, you should aspirate nothing. Then, not the drop test. Take 10 ml of saline.
Take 10 ml
push
of saline and push.
And re-aspirate. Keep in mind, you have to push and re-aspirate.
Yes.
Even in the rectus sheath, it will go. But some amount will get aspirated back. If in the peritoneal cavity, 10 ml in the peritoneal cavity will spread in the peritoneal cavity. No drop will come back. So that is a saline pushing test. Next, you put a drop of saline at the
tip of the varus.
Tip nahi. In the adapter base. Tip is inside. And then lift the abdominal wall. This drop will suck in. That is drop test. What is the final test? That yes, you're in the right place. Final test is you attach your needle to the insufflator machine. What in the machine will indicate you, yes, you're in the right place. What in the machine will show you you are in the right place, I can start insufflating. You are doing every day. You connect this to the machine.
Yes.
You have set the machine to 12 or 14 millimeter pressure. You observe the actual pressure now shown. You see the actual pressure now shown.
What are
it
the
will
things
be less than 10.
What are the things you can see in the insufflator? What are the indicators there?
What are the indicators? One is
abdominal pressure.
One is set pressure. One is set pressure. Second is when you connect and make the machine on, this will show the pressure at the end of the needle. So actual pressure. Next display will be
abdominal pressure.
No. Okay, bhai. Set pressure and actual pressure will come on machine instead on. Next will be flow rate. You can adjust the flow rate from 1 liter to 20 liter or 40 liters depending on the variety of insufflator you're using. And last extreme right will be the volume of carbon dioxide delivered from the machine. Some may be wasted. If you are keeping this thing outside, the whole thing may not be going in. So total volume of carbon dioxide used will be the last display. So what Dr. Das has asked is what display you see in the insufflator. So in the insufflator you can see the set pressure that will be showing all the time. Next will be the actual abdominal pressure when you start insufflating. Next display will be the volume of flow per minute. Volume of flow per minute. And the last will be the volume of carbon dioxide delivered from the machine. Okay, fine. So final test is attaching to the insufflator machine. If the pressure is shown 10, 12, 15, 16, you are not in the right place. Pressure should be less than 10. Usual pressure is usually 4 to 6. Abdominal pressure. You are in the right place. And the insufflation start. Okay. Carry on. You are starting insufflation. How long you continue to insufflate?
Sir, when abdominal pressure becomes approximately 12 to 14 mm.
You have to set one. It cannot be 12 to 14. Either you have set to 12 or you have set to 14.
Yes.
You have set to 14, you wait till the pressure becomes 14. You have set to 12, wait till the pressure comes to 12.
After the creation of pneumoperitoneum, various needle will be removed, and we will insert a telescope attached with a light cable.
After various, how can you put the telescope?
After that, we will insert a 10 mm trocar.
Yes.
It will be a blind procedure, so we should go smoothly, and
what are
that we will. Sir.
What are the indications? How will you feel that you have, because it is a blind procedure? How you can feel that there is trocar is within peritoneal cavity?
Sir, there will be the loss of resistance, sir. If we will in the peritoneal cavity.
And what else? Once you are going inside, if you are using a storage trocar cannula,
yes.
Once you are going inside, you will have a lot of resistance and there will be hissing sound of carbon dioxide coming out. So stop at that point.
How carbon dioxide comes out to the trocar?
Have you observed anything in the trocar cannula? Yes. If you see the trocar, the all trocar does not have the opening. If you made local trocar, they don't have the openings. In storage trocar, you find there are side holes in the trocar tip. So once in the peritoneal cavity, you have already inserted carbon dioxide. That carbon dioxide will come to this hole and escape to the proximal end of the trocar. So once you find that hissing sound, you should appreciate that you are in the peritoneal cavity. Don't push further. You can cause injury. So once the hissing sound comes, once you have loss of resistance, you stop there and take the trocar out. So first port is inserted. Next.
after that we will insert commonly 30-degree telescope attached with the light cable, and then we will first explore the
You have to make a complete statement. You said 30 telescope attached to the light cable. Is that all? You don't fit a camera.
video.
Everything is made ready. So the telescope attached to the miniature video camera and the light cable, then you are ready. So telescope goes in. The camera doesn't go in. The telescope goes in, and you have the picture in the monitor. What do you do first?
So first we will look for the look at this operative site.
No, don't go to the operative site. You have inserted the blind tracker. You have pushed a blind tracker. So the first thing you do with the telescope is you see at the site of entry of the first tracker for any bleeding, for any gut injury, okay, or any vascular injury. So the first thing to focus on insertion of the telescope is inspect the area of first port entry, exclude any injury. It's not there, then focus the area of interest. You may not see the gallbladder. You have not made the other ports. So once you go in, you may not see the gallbladder. But what you can see is the remaining peritoneal cavity. You can see the liver. You can see the part of stomach, part of small gut. But you see, thorough exploration is not easily done while doing a routine cholecystectomy, because you have a radial diagnosis. Your target of area is the right hypochondrial region. So no one goes to do every routine examination, because then you have already have a USG of the pelvis. Okay, so unless required, no one. But standard description is you should have a thorough inspection of the peritoneal cavity. That's done. No damage done. Next.
Then with the help of telescope, we will make a incision over the epigastric region, subgyphoid region, 1 centimeter subgyphoid incision, and then we will insert a 10 mm trocar and through the through the epigastric through that incision. One 5 mm one incision is made at the below right subcostal region at the level of mid clavicular line. Through that at that side 5 mm port is inserted, and one more 5 mm port is inserted at the level of mid axillary line. Mid axillary line lateral to the previous port along the line of umbilicus.
Yes.
After that, tooth grasper is inserted through the lateral port, and to hold the fundus of the gallbladder, and one grasper is inserted through the 5 mm port to hold the Hartmann's pouch, and through the epigastric port we will insert Maryland. And
because it is 10 mm port, so what else you have to introduce before inserting this Maryland?
So reducers.
Yes.
Then we will start. Then we will first start dissecting.
No, you have hold this fundus. You have hold the Hartmann's pouch. You have told. What is the direction of the force of these two instruments?
Fundus of the gallbladder should be retracted upward and outward toward the shoulder, toward the right shoulder, and Hartmann's area should be retracted downward and outwards.
What is the purpose of this letter pulled towards downwards and outwards?
Sorry, sir.
Why do you retract the Hartmann's pouch down and laterally?
So so that the callots area will be visible more clearly.
So to expose the callot triangle area, you do this maneuver. Okay. Then what is callot triangle?
Sir, callot triangle, it is bounded superiorly by the inferior surface of liver, inferiorly by the cystic duct, and medially by the common hepatic duct.
This is in fact cholecystectomy triangle.
Yes.
Where the cystic artery is as a content. But you go by callot triangle proper. Some people say the upper boundary is a cystic artery. Okay. Cholecystectomy triangle is this liver, common hepatic duct, and the cystic duct.
Surgical callot triangle. Callots originally described the triangle with the upper margin was the artery.
Okay, fine.
Okay.
Next. Keep on describing. Finish up.
Then
You have 5 minutes to describe.
Then we will start dissecting the callots area. We will first go for posterior dissection. Then we will go for anterior dissection, and
You are not mentioning what you are doing. Decision means what?
We will strip of the peritoneum attached
Yes.
to the cystic
Yes.
pedicle, and make a
You see the difference. You are seeing, you are observing, but you cannot express in words. So that is important. You have to express in words. So you have two layers of peritoneum covering the cystic duct and the artery. We discovered cystic pedicle. So what you do in your practice, you hold the peritoneum close to the Hartmann's pouch. You can buzz and then strip posterior and then start dissecting the posterior to the cystic duct. Then come to the anterior. You buzz the anterior peritoneum and strip up the anterior peritoneum. Then what do you do? Once you strip the peritoneum, what is your next job?
Then we will make a cystic duct and the we will make a
Describe the term properly. So you use a meridian dissector to dissect or around the cystic duct and the artery. That means you make a tunnel around the cystic duct and the artery. What next to be done before you clip? You have stripped up the peritoneum, anterior, posterior, and you gone around the cystic artery. Now is not advisable to clip the duct and artery at this stage. What is to be done next?
So we will first look for any anomalous
That you are looking for,
anatomy.
but you should be conversant that now the dictum is you have to attain the critical view of safety before you clip the duct and artery. So for that, you need to mobilize the lower third of the Hartmann's pouch. So you dissect the lower third of the cystic plate.
You have to make it free from the base of the liver.
Yes.
The base of the
So 1/3 of this Hartmann's pouch area in the body of the gallbladder should be dissected, and you can see the liver. And once you are now holding, you find two structures going into the gallbladder, and in between you can see the liver.
Yes, and it is nothing returning to the liver.
Yes. So that is what you should achieve. Your description should be: after I dissect the cystic duct and artery, I will strip up the cystic plate, at least for 1/3 of the distal gallbladder, and make a tunnel around. And I will ensure that I can see the cystic duct and artery enter into the gallbladder. And then next step is?
Then we will then we will apply clip over the cystic artery. At least 2 clips should be applied. Preferably, we can apply 3 clips also. And then cystic artery cut by the endoscissors. After that, a clip is applied over the cystic duct. Two clip is applied along the side of CBD, and one clip should be applied. One clip is applied along the.
Make your English strong. Yes, in one sentence, 3 clips are applied. 2 being towards the common bile duct side, 1 towards the gallbladder side. Finish. And then cut in between these 2 and 1 clip. Finish. Why are you fumbling so much for just applying clips?
Then cystic duct is cut by the endoscissor. After that, we will start dissecting gallbladder from the liver bed by the help of hook or spatula. And the gallbladder is after removal of gallbladder from the liver bed, we will insert endo bag or into so that the gallbladder is to put gallbladder into the endo bag and remove through the
removal removal from the liver bed, what your left hand will do?
So we will retract the gallbladder and outward and
yes. So there must be a traction and counter traction. That term is commonly used. So you have to give some traction so that your diathermy works properly. Otherwise, there will be burn. There will be no separation. You have to give a traction, and that another forces by your assistant, they had pushed the fundus towards the liver, so that will give the counter traction. So it will be easily separated. Okay, continue.
After that, we will remove gallbladder through the epigastric port, and then we will look for the liver. Look at the site of liver bed whether any oozing is there. We will irrigate the liver bed area, and if required, drain is placed. And then port closure is done.
Is the same closure for 5 mm and 10 mm ports?
No, sir. For 10 mm port, we should close the sheath also.
Yes.
But for 5 mm port, there is no need of.
So the 10 mm port, the sheath should be closed with polyvactin suture. But 5 mm port, you just can close the skin. It's not required to close the sheath. Yes.
Suppose you are dealing with a very large stone, then during removal it may be problematic. What are the steps you can adopt?
Sir, we can increase the incision site of the epigastric port,
and you can use also the umbilical port also. It is easily, you can extend it easily. It can be removed through umbilical port also. Yeah, for that you have to change the camera towards the epigastric port. Or you may have to crush it. If it is a soft stone, you may crush it with some instrument, and you can remove it. Okay. Now, what are the complications?
Of lab cholecystectomy.
Yes. So there could be hemorrhage, infection.
Oh, again, stick to the basic things. You are doing lab cholecystectomy. So you have to divide the complications. There are some complications related to the access. While going in the veins, while going in the trocar, there are some access complications. Next, there is a complication related to the induction of the neoperitoneum itself. You are putting carbon dioxide. There are a lot of complications described with use of this stretching and the use of carbon dioxide. And then come the specific complications of cholesterol itself. So what are the access complications?
So there could be injury to the underlying viscera,
Like
stomach, colon, duodenum, pancreas, and there could be the bile duct injury.
नहीं रुको ना, access complication bile duct injury कैसे होगा? Access complication. You have not seen bleeding in access complication. Bladder injury? Yes. So these are the important injury related to the access. Then what can happen because of this pneumoperitoneum?
There could be right shoulder tip pain.
That is a residual carbon dioxide. Patient can have cardiac arrest on table. Patient may have arrhythmias. Why arrhythmias? Why patient with carbon dioxide pneumoperitoneum may have arrhythmias? What happens to this carbon dioxide when you insert into the peritoneal cavity? This is one advantage and disadvantage of carbon dioxide. Carbon dioxide is a highly diffusible gas. Once you insert the peritoneal cavity in the carbon dioxide, that gets absorbed. And this carbon dioxide in blood does not cause embolization because it is the water soluble. It gets combined with water and forms carbonic acid. That goes to the pulmonary bed and splits to water and carbon dioxide. You will often find that the anesthesia is hyperventilating to wash off this carbon dioxide. If this carbon dioxide remains in circulation, this hypercarbia can cause different types of cardiac arrhythmias, including asystole. And another reason for cardiac arrest is what? Patient may have cardiac arrest once you start insufflating. When? If you are doing very rapid insufflation. Okay. So if you are starting the insufflation, you are doing very rapid insufflation, there will be compression of the IVC, reduction of venous return, and patient may have hypotension and shock. So one should be cautious while insufflating the peritoneal cavity. This stretching of abdominal cavity, diaphragm may get splinted. Patient with COPD may have aggravation of hypoxia because diaphragm gets splinted, already the lung bed is compromised. So these are the general complications related to access and the pneumo. Now come to the gallbladder itself, where you may have some specific complications like there you start with hemorrhage. Okay, because you see the exam is a situation where you should impress the examiner. When a question is being asked, if you answer in a methodical manner, you get more weightage. So hemorrhage, what else?
Hemorrhage, infection, injury to the bile duct, post-cholecystectomy syndrome.
Talk to the immediate post-op. While doing dissection, you can't injure other viscera. This has happened number of times. If there is a gross adhesion in the gallbladder bed, you can injure the duodenum. You can injure colon. You can injure stomach, what not. You can injure the portal vein.
Even inadvertent injury using the diathermy also. You can use diathermy, you have to be very careful. It may be carried to the duodenum. If suppose a tissue
can be
is
thermal injury.
Pointing towards the duodenum and you are burning it.
And there is another important area being described where it is described as injury due to coupling. Okay. So a lot of coupling injury occurs while using diathermy. Okay.
So is there any contraindication of laparoscopic cholecystectomy? You may have to adopt open cholecystectomy.
Sir, if there is if there is gross adhesion, then we have to go for conversion.
Gross adhesion means you are not able to approach. That is one. But Dr. Das will ask a specific question. Any contraindication where you should not venture for laparoscopy?
So there are two questions. When you adopt, when you convert, or when you plan for open from the beginning. The question is when you plan from the beginning, you will go for open cholecystectomy, not laparoscopy.
If you say now one absolute contraindication, that is if you are suspecting malignancy in the gallbladder. In that case, if you are conversing doing a lab radical cholecystectomy, yes, you can proceed. But in that case, simple cholecystectomy is not advisable by laparoscopy if you have suspicion of malignancy in the gallbladder. Earlier, cirrhosis was a relative contraindications. Now people have come with modifications. They can do lab chole in cirrhotic patient, but relative contraindication is also cirrhosis. How you have gross cirrhosis, it is difficult to manage the bleeding.
Okay. Yes, contraindication varies with the experience of the surgeon and the situations there. Also that.
Then other contraindication like coagulopathy, patient is unfit for general anesthesia. They are all general contraindications.
And first and third trimester of pregnancy is a relative contraindications. Yes. Now, when you convert,
when there is gross adhesion, when there is bleeding, which
if you say only gross adhesion is not contraindication. If you have gross adhesions and you cannot progress the surgery by lysing the adhesions, there are a lot of bleeding, the anatomy is not clear, there might be underlying viscous which is densely adherent, then only you consider. So finding gross adhesion is totally does not convert. You attempt to lyse the adhesion, but if there is no progress after doing this attempt for lysis, then you should convert. If you suspect that some viscera is densely adherent there and you cannot manage laparoscopy, you see, now if you say conversion, some surgeon will say, I never convert now. Because whatever you will be doing on opening, he will do it laparoscopically. But for an average surgeon, for a beginner, there is always a situation that you should convert in situations like this. Dense adhesions, difficult to lyse the adhesions, and there is no progress after a reasonable period of time. You should
for example, in as Professor Shah had mentioned, the high grade is acute cholecystitis. You may have to convert.
Yeah.
Then any other late complications?
Post cholecystectomy syndromes.
Total. Post syndrome is a general term, has a number of things, and what specific late complication can occur.
Biliary stricture.
Yes, biliary stricture, benign biliary stricture, and some patient can come back with port site hernia.
Yes, port site infection is a very.
Dr. Das, you like to share some points,
yes.
How to approach?
Yes, you can share.
Again, Onkar, I do not like your approach. I am always in favor of dividing the description of operation to salient steps. Okay. You see, these are the usual indications for lap cholecystectomy.
So cholecystectomy may be open mini lap or lap, and advantages you have mentioned. So these are the advantages of laparoscopic cholecystectomy. So surgeons have adapted for this laparoscopic approach. And so indications, some are for gallbladder itself and due to stones, and some are without stones. As for example, perforation, traumatic rupture and gallbladder perforations, there may not be any stone, but some from acalculous cholecystitis also, as for example in severely diseased patients, there may be acute cholecystitis. So we have to remove without stones. And some are polyps, as you have mentioned, there is a large polyp and it is more than 1 centimeter, or multiple polyps, or size of the polyp is increasing. So these are also indications other than the stones. Along with that, other procedures like Whipple's operations, liver resections, choledochal cysts, and like that. Also, some in case of chronic pancreatitis, we are doing lateral pancreatic jejunostomy. In some cases, you may have to do for cholecystectomy. Now, so laparoscopy is now gold standard, as you have mentioned. Now, for pneumoperitoneum, you have told it is important in confirm the varus needle position. It is important, you have mentioned correctly. So you have to be very sure that it is in the position before insufflation.
The first step is induction of pneumoperitoneum.
Yes. So after pneumoperitoneum, you have to place the subsequent ports, and you have mentioned the epigastric port. You have to be careful so that you can place it just right of the falciform ligament.
Yes, you have not mentioned that. You said I put a biggest jump. You should keep in mind that this is under vision. You dip with your finger and see they are going to the right of falciform ligament.
Yes, otherwise you may have to a great problem during removal also of the gallbladder with epigastric port. And now you have mentioned what are the steps. You have mentioned correctly, and you have to pull down the downward, outward the left with your left hand to make it square, to make the triangle a square, and you can get a diagonal with the cystic artery. Now we have mentioned all these things. So actually, there is a question whether we will clip the cystic artery or cystic duct first. There is no standard dictum in laparoscopic cholecystectomy, but in many situations, cystic duct may be straightened if you clip and cut the cystic artery first. You can get a longer cystic duct to clip. You can see it better.
The dictum is artery first and then the duct.
Yes. So you have to wash it. Now you have removed the gallbladder. It can be removed also through the umbilical port also. So drain is according to your option, whether it is your field is perfect, there is no spillage of bile at all. So you may not have placed the drain. Otherwise, you have to place the drain. Closure you have mentioned. There are several techniques of closure, especially for the umbilical port, and you have to use. You can use some form of trockers to remove it, or you can place the sutures during the placement of the initial trocker also, and then close it. Now these are some contraindications that Professor Shah had mentioned. And patient unable to tolerate general anesthesia, because in laparoscopy general anesthesia, though it is nowadays it is done in spinal anesthesia also. And frozen upper abdomen, you anticipate that there is a number of multiple surgery in the upper abdomen, open surgery. You expect that upper abdomen will be frozen, you can adopt open cholecystectomy. And these are some relative contraindications. So this is portal hypertension. You can appreciate the bleeding from the portal venous tributaries around the gallbladder. And in case of advanced acute cholecystitis, as Professor had mentioned, grade 4 acute cholecystitis and pregnancy also may be a relative contraindications. Now all that regarding laparoscopic cholecystectomy. So now
Onkar can describe in quickly the steps of open cholecystectomy. Onkar, and go by salient steps. You see.
starting with the anesthesia, we will go for general anesthesia with endotracheal intubation. After antiseptic dressing and draping, we will make a subcostal incision. Make a subcostal incision. Then we will after.
While you are going to the incision subcostal region, when you cut through the structures, are the structures same throughout the whole incision, layer by layer, or they are different? What difference? You read this slide. Once you cut the skin subperitoneal tissue, the next layer is medially under rectus sheath, laterally externally appendages in the muscle. Once you incise the layer, the next layer medially is rectus abdominis muscle, and laterally the internal oblique appendages in the muscle. Once you divide the rectus muscle across its fiber and inside the internal oblique, the next structure exposed medially is the posterior rectus sheath, which is muscular, and go laterally, you are going to the transverse abdominis muscle and deep to that surgical peritoneum. So if you are describing a right subcostal incision, you have to keep in mind all the structures are not same, you are cutting from medial to the lateral side. The structures are different medially and laterally.
Yes, and medially, this posterior rectus sheath and this parietal peritoneum and this extraperitoneal fatty tissue are combined, cut together. For that, they are called surgical peritoneum together.
There is a composite posterior rectus sheath, which is a blending of all the layers. But if you go laterally, the sheath ends, and laterally find the transverse abdominis muscle and deep to the surgical peritoneum. So you have to keep in mind the description of this incision. If you are just given a card of open cholecystectomy, examiner will stick to this part at least. Yes. And then the next heading is preliminary. You cannot do the whole exploration by subcostal incision. Keep in mind. You cannot do a thorough laparotomy through its right side. And that is not desirable also. You are not going into the abdomen for doing a exploratory laparotomy. You have a symptomatic diagnosis, you got a clinical diagnosis, the plan was to be cholecystectomy. That's why the incision is this. But limited exploration is possible. Through this, you explore the stomach, duodenum, colon, and pancreas.
And we will place mop.
Yes, placement of mops for exposure of the callostrangular area. Same again. So where do they put the mops? Where do you put the mops?
One mop should be placed at the site of hepatic flexor.
Yes. So 1, 2.
One at the site of duodenum, transverse colon.
Yes.
And,
Next medial is the next mop to retract the transverse colon and the duodenum. And most medial is to retract the stomach and duodenum. So 3 mops are standardly placed. And what is next?
Then we will retract.
Yes.
Retract the retract one retraction should be at the upward of the
so one deverse retractor to lift the right lobe of the liver. One assistant will hold a deverse retractor to lift the right lobe of the liver. And then what surgeon will do now?
And the other deverse retractor should be in retract.
It can be either deverse retractor, or if you go by original description, it's the left hand of the assistant. Either deverse or it's a left hand assistant who will expose you the area of the portal. And surgeon will hold the fundus and the Hartmann's pouch by using 2 pair of Moynihan cholecystectomy forceps. And again, the retraction is same. Fundus up and outward, Hartmann's pouch down and outward. And the callostrangular area is exposed. Next.
Then we will strip off the peritoneum.
Yes. Next heading is again dissection of cystic pedicle. So you strip off the peritoneum anteriorly, strip the peritoneum posteriorly. Using a right angle forceps, you make a tunnel around the cystic duct and the artery. And as is done in lap cholecystectomy, here also you should strip the 1/3. No, you strip 1/3 of the gallbladder of the cystic plate to achieve the critical view of safety. Then pass ligature around. Pass ligature, 3 ligatures to the duct, 3 to the artery. So artery first and the duct next. And then divide. Using electrocautery to take the gallbladder out. So you see, this part is same for open and lap. The axis is different. So achieve hemostasis, irrigate, put it in. And how do you close this incision?
Now we will go for, now it is the recommendation that we can go single closure.
You can do single layer closure using a PDS suture. And if you do a layer closure, even layer closure is also advised or described. You can close the posterior rectus sheath in the same line, close the surgical perineum, transverse internal oblique. That is one layer. And next layer will be the anterior rectus sheath and the external ligament neurosis.
Yes.
Okay, Dr. Dash, you can conclude by asking
Yes.
last few questions. Somebody has made a comment in the box that when the gallbladder is diseased, CBD is already dilated and storing bile. Yes, most of the situations this happens. If the gallbladder is fibrosed, the cystic duct is blocked, the bile is not going to the gallbladder. You often find the gallbladder contains only stone. There is no bile. So already bile duct is a storage place for the bile.
Yes. So gallbladder is diseased already. So that is the cause you have to remove.
Any more questions, Dr. Dash?
Hello,
Yes, Dr. Moshak.
Mahunda,
Yes,
Professor Shah, good morning, and Professor Mukhopadhyay, good morning. I want to highlight 2 or 3 things. One is, if we operate incidental gallstone and there is a complication, is there any medical legal issues?
No,
One.
you have to justify, na? As I said, Tata Memorial Hospital has a publication saying that people in this endemic area should undergo cholecystectomy because there is high incidence of gallbladder carcinoma in this region. You can always justify why your patient has come to you with some complaint. So doing operation for a silent stone is not a legal offense. No.
So you have to justify yourself before going to the operation, not
Yes.
after the complication.
Yes, yes.
Yes.
Okay.
Why are you doing it? You must have the.
No, you have all the points. You have points
Yes.
to justify doing
Yes.
surgery in silent gallstone, particularly in this region of the country,
Yes.
where you have very high incidence of gallbladder cancers, particularly in young patient. You can always justify.
Yes.
Question 2 is, we should discuss few words about the subtotal cholecystectomy, but sometimes nowadays with the ultrasound, we get more and more clean-cut gallbladder, but sometimes we get a very difficult gallbladder where the callus is frozen. So the new generation should be aware that we can do a subtotal cholecystectomy, because this is actually a surgeon's nightmare, and we can do a subtotal cholecystectomy.
If you go by standard
Comment
description,
from Professor Saha.
yeah. If you go by standard description, in situations like portal hypertension, in
Yes.
situations like acute cholecystitis, when the callus area is frozen, you should not venture to do a complete cholecystectomy. So there are 3 types of subtotal cholecystectomy. Type 1 is the neck area is frozen. You open the gallbladder at the neck, remove the stones, overrun the neck area using a polyglactin or other suture, and then take the remaining gallbladder out from the bed. That is type 1 subtotal cholecystectomy. Another situation is you have cirrhosis of the liver. The callus area is clear. So you dissect the callus-tangle area, divide the cystic duct and artery, but do not try to take the gallbladder posterior wall out from the bed. If you open up a sinus, you cannot control that bleed, patient die on table. So in that case, what you do is, after tackling the callus-tangle area, you intentionally leave behind the posterior of the gallbladder in the bed and take the anterior out. This is described as type 2 subtotal cholecystectomy, and you have to cauterize the mucous membrane in the gallbladder bed.
Yes.
When you have a combined difficulty, you have frozen callus, you have very deep gallbladder, which is very inflamed, and you cannot take this gallbladder wall out from the bed, you can do a combined procedure of leaving part of the neck and leaving the posterior wall. This is described as type 3 subtotal cholecystectomy. This you need to adopt in difficult situations. So these are the options and types of subtotal cholecystectomy. I hope Dr. Basak, I have answered your question.
Yes, fine.
Another.
I want to mention 2 things. Hello.
Yes, please.
I want to mention 2 things. I think the postgraduate student should tell about the bile leak from the liver bed, and venous sinus bleeding as the complications of laparoscopic cholecystectomy. Because these are two tedious situations which we made. Comment from Makhanda.
Yes, yes. You see, we could have asked a different question that way. While doing surgery, you find there is a bleed from the sinus. What you should do, Onkar? Dr. Bosak has raised the issue. While doing the surgery, you have descended the gallbladder of the bed and a sinus is opened up. What you should do? And what you should not do?
So we will suck out the contents.
Keep on sucking, it will come on. It will come on. The option, the answer should be once the sinus opens up. It is very difficult to control this bleed by using cautery.
Yes.
The first thing to do is put a gauze piece, keep a pressure for about 10 minutes. Don't try to use monopolar cautery. If a compression of this sinus with a gauze piece for about 10 or 12, 15 minutes, the bleeding may stop. Don't do anything.
Yes.
If there is a minimal bleed, you can try with a bipolar cautery, not a monopolar cautery. If you cannot control with bipolar cautery, the best option is to put a ligature.
Yes.
You put a figure of 8 suture at the site of this bleed. Next question was,
initially you can use the gallbladder itself also for pressure.
Yes. Some form of compression using the gallbladder or putting a gauze piece. Second is, while doing surgery, you find there is a biliary leak from the gallbladder bed. So this leak can be either a very small duct which is leaking. Standard description is, if you find a small duct is leaking, you can easily clip or ligate it. But if the duct is a sectoral duct which is more than 3 millimeter, in that case, ligation may cause cholangitis. In that case, you need to do a bilioenteric bypass. So small biliary leak should be controlled with suture or pressure. If it is a small leak, you can just ligate it. If it is a sectoral duct which is more than 3 millimeter, one should consider doing a bilioenteric bypass.
3 millimeter is the border. 3 millimeter is the borderline, is the landmark. Right?
Yes.
And for a young surgeon, it is that you don't have to go for complete dissection of the cystic duct. You don't have to reach up to the common bile duct.
Yes, the dictum has changed. Yes. In our student days, the dictum was find the tri-junction of cystic duct, hepatic duct, and the common bile duct. Now the dictum is dissect at the junction of Hartmann spouse cystic duct junction. Don't venture to go to the cystic duct bile duct junction because the artery of the bile duct runs in 3 and 9 o'clock. You can injure the 9 o'clock artery if you are trying to dissect the junction between the cystic and the artery. Keep little away from this point. Keep close to the
heart. If you have adequate length for pressing the clip, that will be enough.
Yeah. Okay, we can conclude. Thank you, Dr. Dash.
Can I add 2 or 3 points, Makhanda?
Very quick. We have 15 minutes.
Point one is there is a saying that if you are lateral to the cystic lymph node of lung, you are less likely to damage the other issues. This is one point. And I think our new generation should know at least mentally the Hogarth-Pringle maneuver, which we should discuss for 2 minutes, because if any bleeding, they could convert and manage it like that. Because otherwise, if they continue laparoscopically, this will be a disaster. Hogarth-Pringle maneuver is a time-honored thing. I have saved myself several times by the inflamed gallbladder, ruptured cystic artery. So Hogarth-Pringle maneuver, you should tell them for 1 or 2 minutes.
Yeah. The point is, apart from cystic lymph node is not a constant marker. The more important marker is discovered the rubeoid sulcus. It is sign that you find the rubeoid sulcus in the liver bed, you should not go below that. Below the rubeoid sulcus comes the bile duct. So you should always try to be away above the rubeoid sulcus, because cystic lymph node may be variable. Next is Pringle maneuver. It is difficult to apply the Pringle maneuver in laparoscopy because all the instruments are coming from the sides, and with this instrument, if you catch, it can cause trauma. Pringle maneuver is applicable in open surgery, or if you want to do at all a laparoscopic Pringle maneuver, you have to use a endovascular forceps. You can
Yes.
apply the endovascular forceps in the aorta and then go for conversion. In open surgery, you just press with your fingers. You press index finger and middle finger behind the iliac foramen and thumb in front, and then press. That is a Pringle maneuver. You buy time, you control the bleed, and you can manage the situation by using this Pringle maneuver. Agreed, Dr. Bosak?
Yes,
So
yes, yes.
we
Thank you.
conclude today.
Thank you, Dr.
Thank you
Basak.
very much. Thank you, Dr.
Thank
Das,
you.
Dr. Bosak.
Yes.
Thank you.
Thank you. Thank you.
Thank you.
Bye.